these are some things you need to pay attention to. Remember that turgor really doesn't apply to the young children less than about 1 or 2 maybe, and the geriatric crowd. Anything over than, well, I'm 58, so mine's doing pretty good right now, so you gotta be older than me. Now, examination of the shoulder. Remember, the shoulder is not just the glenohumeral joint. It actually is an articulation between 4 different bones. The clavicle, the humerus, the scapula, I'm missing something. The scapula, the clavicle, the humerus, the, yeah, three bones. 3 bones. That's all you got. No, it's the sternum. The sternum. The sternum is also part of the shoulder because the clavicle is going to articulate with the sternum. I knew there was a 4th. Okay? So when you examine the shoulder, you need to keep that in mind, that you examine everywhere from the back to the front. It's not just the joint. The AC joint is here. The AC joint is not that bony prominence laterally. That is the greater tubercle of the humerus. That's the AC joint. When Scott Inowitz comes and lectures, I believe on Wednesday afternoon, he's going to talk about AC joint separations because there are degrees in how you treat them. Right? The elbow. One of the things that you want to do on the elbow is inspect the carrying angle. The carrying angle is if you put your arms down by your sides, you'll notice your elbow is slightly flexed. If we get our friendly goniometer here and measure that slight flexion, we'll see that it's about 15 degrees. I'm really not, I just made that up because I don't have my glasses on, I can't see these little numbers, but it's about 15 degrees is the normal carrying angle. I was somewhere the other day here on campus, and there was a guy walking in front of me that was walking like this. So his right arm, upper extremity, had the normal carrying angle, but his left arm was pronated and abducted, and his elbow had a greater degree of flexion. I don't know what his problem was, but this, if you're doing a physical exam on somebody, you would note this. Epitrochlear nodes, when you did the lymphatic system, they mentioned epitrochlear nodes. Where are the epitrochlear nodes? So this is the trochlear part of the humerus here. Epitrochlear is right above it in the depression on either side. So when you're palpating for epitrochlear nodes, you come from the back and you're palpating in this area right here. If you have lesions on the fingers or the wrist, anywhere down in here, you're going to feel palpable nodes there. One of the most impressive epitrochlear nodes, two of the most impressive epitrochlear nodes I ever felt. One came from an 18-year-old with HIV, and he didn't know he had HIV. He came in because mom said there was a lump in his neck. And it was a huge, it was a lump, it was a lymph node. And he had every node in his body was palpable. His spleen was huge. Generalized lymphadenopathy is a presenting symptom with HIV. He denied any risk factors for HIV. I did a fine needle biopsy of this node. It came back not diagnostic, and ran a bunch of blood tests on him, and I ran an HIV with his permission. He was 18 at the time, so didn't have to get his parents' permission, and it was positive. And he didn't know about it. But he had epitrochlear nodes. The other one is that was cat scratch disease. Cats, you know, my feelings about cats, they harbor all bad bacteria, and they get the lymphadenopathy from a cat scratch is marked. You will not forget it. And if your cats are gonna most of the time scratch you on the hands, and they get these monstrous nodes in here, they'll come in complaining of pain in their elbow, you feel it in just huge nodes, you know, like 2 centimeter, big reactive nodes in the epitrochlear region, and also in the axillary region. Okay? Tinel sign and Phelan sign, I believe we covered in anatomy for carpal tunnel syndrome, a median nerve impingement. The way you do these is Tinel's sign is you hyperextend the wrist, and there's the median nerve there. You tap on the median nerve pretty forcefully. If she has carpal tunnel syndrome, when I do that, it's going to feel like an electric shock goes down her hand or into her hand along the distribution of the median nerve, which, as you remember, is that. Okay. Phelan's sign is, I'm going to get her to put her hands back to back with her elbows up. So you're not doing it down here. Elbows up. And this does the same thing, essentially. It puts compression on the compartment. And she'll, if you can do this for 3 minutes and there's no problem, then you don't have carpal tunnel syndrome. If suddenly she says, well, you know, my hand is going to sleep, then that's a positive sign for carpal tunnel syndrome. Hand. Remember, Finkelstein's test is de Quervain's tenosynovitis. Put your thumb in your right here, or have the patient put their, doesn't hurt the patient when you put your thumb in there, so have them do it. Put their thumb in their palm, wrap their fingers around it, and do like that. And if they have tendonitis of the extensors or abductors of the long abductors of the thumb, it's going to be painful. It's going to reproduce pain. That's de Quervain's tenosynovitis. Ulnar deviation is this. If a patient is, if you're looking at a patient and they are sitting there talking to you like this, sitting there on the table or in the chair, and you see this most of the time in rheumatoid arthritis. Rheumatoid arthritis will, as it advances, will deviate the fingers, the 4 digits here. So note the ulnar deviation. Osteoarthritis produces osteophytes, or overgrowths of bone. These overgrowths can occur on the PIPs and the DIPs. The overgrowths on the PIPs are called Bouchard's nodes. Heberden's are on the DIPs. And this slide here, you can see them. There's the ulnar deviation that you see. It's quite pronounced in this person. The osteophytes you can see on that X-ray right here. The way I remember it is if you're going from proximal to distal, proximal is B comes before H. I guarantee you that's a board question. Osteophytes on the distal interphalangeal joints in a 68-year-old woman who used to be a seamstress is going to be what? It's going to be Heberden's nose. Proximal, the PIPs, is Bouchard's nose. Just B comes before H. You can see them in this illustration over here. You can see essentially right there. You see how that joint is just expanded. Okay. Lower extremity. Lower extremity, These are some of the issues related to the lower extremity. Stasis dermatitis. When you have diabetics, when you have people with peripheral artery disease, you get a lot of skin changes related to that. And this is known as stasis dermatitis. If it goes unchecked, if it's allowed to progress to the point where there's pressure over these stasis areas, they'll usually have skin breakdown and the formation of decubiti. Especially diabetics, an absence of hair is one of the early signs of peripheral artery disease, as well as hyperpigmentation of the lower extremity. Now, the hip, if you're getting into the hip, one of the things that you want to deal with the hip is rotation. So examining the hip, range of motion of the hip, internal versus external rotation, flexion and extension. Trendelenburg sign we went over in anatomy, where you have loss of the gluteus medius, which is the muscle that is primarily concerned with keeping the pelvis over the femur as you walk. So normally your hips are just about parallel to the floor, both sides of your hips, as you elevate your foot to walk. In people with neuromuscular disease or nerve injury involving the gluteus medius, in order for them to walk, they have to situate their pelvis over the femur, over the femoral head. So they have to sit it there, and they have to essentially pole vault over their lower extremity. So raising a pelvic tilt as you walk is a positive Trendelenburg sign. Thomas test is an interesting test because in the geriatric crowd, you'll see a lot of the older folks like this. So, are they like this because they have, is it the spine that's bent? Or are they having contractions of the hip? And because the iliopsoas, as you age, can tighten up. And as it tightens up, it draws you forward. This is the disability thing. The Thomas test is, can I get you to, this is an easy one. The Thomas test, if you'll lie down here. The way you do the Thomas test is, if you've got a little bit of, now people, they don't typically go straight over. They typically will bend one way or the other, right? So if she's bent, let's say this is the affected side. She's bent this way. What you do is I want you to take this leg, pull it all the way up, like that. So you see how her hip stays on the table? A positive Thomas test, if she has a contracture here, her hip will come up. So that's telling you there's a hip contraction versus spine. Thank you, ma'am. Knee. The knee is an animal all unto itself. Let's get Larry down here for the knee, because he's got the shorts on as well. So there are a whole bunch of tests for the knee that we want to do. And can we clear a space for him here? Because I want you guys to do this on each other when we start practicing here. All right, so if you'll lie down. All right. Okay, there are a whole bunch of different types of knee tests. We'll save the anterior and posterior dorsal. Well, we went over that in anatomy. Anybody have any questions for it? It's because your cruciates are this way, it prevents the anterior and posterior displacement of the knee. All right, which is the same thing as the Lachman test. So what you do with the Lachman test is you stabilize the foot like this. You've got the knee flexed a little bit. You get behind it, with your hand on the foot and pull forwards, and you're looking for anterior displacement of the knee. Put that one down. Compare it to the other side. Okay? All right. That's Lachman's. Apley's maneuver is, if the chief complaint is popping, clicking, locking, it's probably a meniscal problem. So let me get you to roll on your stomach there. If the problem is in his left lower extremity, what we want to do here is we want to grind the head of his tibia into the femoral condyles. Right? So the femoral condyles are coming down like that. We're going to take the tibia up like this. So his menisci are sitting on those condyles, right? Now with a big guy like him, what I typically do is I put my whole body into the effort. I'm going to do something. I'm going to get like this. I'm going to take his lower extremity and I'm going to grind it back and forth like that. If he's got a meniscal tear or a meniscal damage or osteoarthritis and no meniscus, that's going to be quite painful. Okay? You can roll back over. All right, now this is the one I want you to practice on each other. Go ahead and lie back for here. It's the McMurray's test. Now, this test is, I don't know, did I demonstrate these to you in anatomy? So this is the one I want you to demonstrate on each other because you got to get the feel for this. All right, so you're going to test cartilage and ligaments with the McMurray's test. So what I'm going to do is I'm going to get you to, I'm going to flex your knee like this. I'm going to rotate the foot inward, and I'm going to rotate the knee outward like this. And then as I straighten your lower extremity, I'm going to put downward pressure on the knee. Or just relax your knee. Let me move it. All right? Just let me do it. You see, I've got his knee bound right there. All right? So what I'm doing is his femur is out here and his tibia is here. I'm putting stretch on the lateral collateral and I'm grinding the medial meniscus by doing that maneuver. You see, I'm up, I'm in, and so I'm putting stretch out here and I'm grinding these two heads together. The next thing I do is I go the other way. I laterally rotate the foot and I push inward as I take it down. Now I'm stretching the medial collateral and grinding the lateral meniscus. All right, so you can't just do this like this. You know, you've got to get the knee bound. And it's much easier in a small person than it is in him. But you need to practice that on each other. Now, if you've got if you've had ACLs and stuff like that, don't do this. Don't let anybody do this on you. But if you're examining the knee, that's what you need to do. Finally, and I didn't put it on the list here, is the patella should track between the two condyles of the femur. It should normally track there. So, and there's, if you remember from anatomy, there's a retinaculum that attaches it both sides that tracks it in that middle compartment. Most of the time, knee problems from walking upstairs, that's painful to walk upstairs, are due to the fact that the lateral collateral ligament is pulling the patella off line. So what you want to do is simulate that by just flexing the knee, grabbing the patella with your fingers here, moving it laterally as you straighten the knee. And if they have a patellofemoral syndrome, it's going to be painful. Ballottement, if he has a fluid in his knee, you can sit there and push on the patella and it's floating in the effusion. It's essentially, not really floating in it, but the effusion is in the capsule. the patella is outside, and once you feel ballottement, you'll know it. Okay? You can also take your hands and if there's suspicion of effusion in here, you can milk it into the different compartments. The thing about the knee is that the bursa surrounding it, other than the pre-patella bursa, the other bursas surrounding the knee all connect to each other. And you can sit there and milk. If you see an effusion, a boggy effusion, you can usually press on it and squeeze it to the other side. Okay? And you can squeeze it up here. You can squeeze it from up here down here, just by applying pressure. And finally, valgus versus varus strain or stress. A inversion, or as the knees, like knock-kneed, that's valgus. And I always remember that because you kind of look like an L, right? That's valgus. Bow-legged is varus. So when you say valgus versus varus stress, you're just simply taking the knee, the extended knee, and putting pressure on it from the outside, and then from the inside, you're putting varus and valgus stress on the knee that's testing the collateral ligaments. Right? The ankle, the drawer sign, thank you, Larry. Can we get you, Kayla? If you're just, actually sit on the end down here, gotta be on the end. No, pick on you because you have sandals on. The anterior drawer sign is testing for the stability. If you'll sit up there, we just scoot back. I just want you to end right there. It's testing for the impact. What's the most commonly injured ligament in a sprained ankle? The anterior talofibular. So that runs right here. Can I take your shoe off? No? Okay. So what this does is it prevents the foot from coming forward. Right? If the ligament is there, it prevents the foot from coming forward. So the anterior dorsine in the foot is nothing more than you stabilize the lower extremity, cut the heel here, behind, right there, and slide it forward. If the ligament is intact, you won't be able to slide it. And compare, of course, with all of these tests, you're comparing one side to the other. If she has a torn anterior talofibular, you'll be able to move the foot forward. You'll be able to move the foot forward asymmetrically. Right? There you go. All right. There was one I missed. Right here, supine and sitting straight leg raise test. I want to make sure that you understand this perfectly well. Can I have you down? No. All right, so. Okay, just sit right there with your. All right, so if she's complaining of back pain, lumbar back pain is radiating into her left butt, down her left leg. So, and I think I demonstrated this in anatomy, but you got to be sure you understand it. So if I extend her legs, notice that her hip is flexed. Hold it like that. Notice that her hip is flexed to 90 degrees. So as she's sitting there, I'm doing the exam. I'm saying, now I'm going to straighten the leg. Does this hurt back here anywhere? Okay, let's come over here. Does this hurt back here anywhere? and I'm grabbing, and I'm touching the popliteal space here. Because what I'm doing is I'm focusing her attention here. If she has true back pain, then if I flex her hip to 90 degrees, it's going to truly exacerbate that pain. Okay? If she's malingering, she's going to say, yeah, that hurts my knee. Or no, that doesn't hurt at all. Because I'm going to compare sitting versus going like that to elevating her leg from this position. When I elevate her leg, the unaffected leg, they usually don't scream and holler. You know, you can get the leg all the way up to here. But as soon as I touch this leg and start moving it, she starts screaming about her back pain. Wait a minute. You're saying that if I elevate your leg to 10 degrees, it's causing you excruciating back pain, yet when you were in a sitting position, there was no problem. You want drugs. Okay? All right, so if you have a positive straight leg raise test when they're supine, for true back pain, it should also be positive sitting. Okay? All right. Any questions about that? All right, so let's just go through this. Who wants to? Brad. Oh, come on down, Brad. Come on down. So we're going to go through and do a quick musculoskeletal exam, and then we'll take a break. We'll split up, and we'll. So we'll have a seat right here. So the musculoskeletal exam is indicated. What you're basically doing, now I'm not doing special tests because nothing lights up. If his knee lights up, then I'm going to go do those special tests. If his back lights up, then we're going to do the axial loading and everything else. But just doing a quick exam on him, here we go. And you just start from head, and now you start from head and you work your way down. Now, you can't, you're not really going to do a musculoskeletal exam in isolation unless there's a specific joint complaint or a specific injury you're focused on. What you're going to do on your physical exam is you're combining the neurologic with the musculoskeletal. Okay, and I'll show you what I mean here. So, as we're sitting here, okay, I'm just going to go ahead and open your mouth, close your mouth, okay? Crepitus, no crepitus, okay? Take your shoulders here, can you reach all the way up? Can you do this? Can you do that? Okay, can you do this? Okay, can you lift against my hands? Can you push down against my hands? Can you push out? Can you push in? So, you see what we're doing here? He has full range of motion of his shoulders. If he did not, then I would say, well, let me do it. I'm doing it against resistance. I push out, push in. I also tested his elbows when I did that. When he put his hands straight up, his arms are at 180 degrees. When he sits there like this, they're now at 90 degrees. I'm doing it against resistance. Now do your elbows like this, all the way up. Okay, now rest them like this. Wrist up, down, in, up. Put your fingers like that, okay? Make your fist, okay? Back out. Don't let me push them together. Put your fingers together. Don't let me pull them apart, okay? Take your fingers and touch your thumb to your little finger. Don't let me pull my fingers through there, right? You're testing strength of his ulnar and median nerve right there. Take my hands. While he's got his hands like this, I just stick my fingers right in there. I'm going to say, squeeze my fingers as bloody hard as you can. Okay? And I'm testing. So I tested his ulnar nerve by abduction and adduction of his fingers. You know, can he move his fingers apart and don't let me push them together? Remember the interossei? Okay? Here we go with the ulnar and median again. Squeezing the fingers. Now, if there's a problem, like, if you see Bouchard's nodes and things like that, then you want to be able to focus in on those. Can you really not make a fist? Okay. All right. Now, while they're still sitting here, can you go out with your, okay, go back? So I haven't tested, I tested extension of his knees, but not flexion. Okay. Now I want to test strength. Push out against me. Pull back in. So now I tested strength with flexion, but not range of motion. Okay. So take your ankles and go up, go down, go in, go out. Okay. Now I'm gonna put my hand on the top of your foot. Push up against my hand. Push down against my hand. Don't let me turn your feet. There you go. Very good. All right, like that. So I tested strength and range of motion of his ankles and his feet. Now, if you'll stand up right here for me. Okay. Go walk to the door. So as he's walking to the door, I'm looking at his gait, looking at his spine. Come back walking heel to toe. There you go. Testing balance, his cerebellum. Just stop right there. Bring your heels together, arms straight out to the side. Just close your eyes. Make sure you get ready to catch them if they should fall with the romper. You can open your eyes and turn around and face the door again. Bend down, touch toes. Slowly come back up. And don't say it that way. Say it that way. Don't say come back up slowly, because when you say come back up, they're going to come up too fast. So say slowly come back up. Okay? There you go. You're testing for, of course, curvature. Okay? Grab his pelvis. Lean back towards me. I already know he can, no, this is not a trust fall. Extend your lumbar spine. Lean back towards me. There you go. Stand up straight. Bend to the left, the right, bend to the left. Turn around and look at me. Okay, turn around the other way and look at me. Well, he's had more limited range of motion than I did. Stand on one foot for me. Stand on one foot. Hop up and down. Okay, stand on the other foot. Hop up and down. That's, look at all the strength in the lower extremity I just tested. Now, can you do a deep knee bend for me? Just stand up. No, put your 2 feet on the ground. Okay, now come back up. Now I got the flexion of his knees. Flexion of his knees. Okay? You can also do things like stand up on your tiptoes for me. Back on your heels. Okay. And there you go. Now, one more thing. Come on back over here. And I do it as part of the EENT exam, because when you look at, go ahead, Pepsi, when you look in their nose, what do you need to do when you look at the nose? Look up at the ceiling. So that's why I'm testing cervical range of motion right there. Also, if I looked up his nose, go ahead and x-ray ahead. You want to rule out meningitis. How do you rule out meningitis? Range of motion of the C-spine. At that point, when I'm doing the head and neck exam, put your chin in your chest and do the rotation. Okay? And that's the part of a musculoskeletal exam you need to do. Okay. Hang on a second. So, DTRs. Now, of course, if any of this is positive, you're going to focus in on it. All right. DTRs. We'll start with the ankle down here. If you take the ankle and you got to relax it, these DTRs won't work if they're not relaxed. So relax your ankle, and I'm going to dorsiflex it like this. Now I want you to push down against my hand just ever so slightly. Push on the gas. And now I'm going to hit the patella. You see it? You see it? All right, he's got a good patella reflex. Okay?
Achilles?
Huh?
Achilles reflex? That's an odd patella.
You have an odd patella. That's not the only thing, but that's a thing. Okay?
It's really.
So everybody saw that, right?
Yeah, look.
Okay. So if you can't get the patella reflex on your partner, find him. You have a good one?
Are you joking with us?
That's the Achilles.
It's Achilles, not.
Oh, that's it, keep saying patella. That's the patella reflex. This is the Achilles reflex. Yeah, sorry about that. All right, so. If you
We're like,
can't
are you
get the
being
Achilles
serious or
reflex, talk to this guy, okay? All right, the patella reflex, you don't need, that's the only one where you really need to have them put pressure or activate the muscle, the Achilles. The other ones, it's just relax your lower leg here, the patella, and don't be in front of them. I can tell you. Or you're gonna, especially if you're a male, come to the side and just tap it, very easy. And when you do reflexes, don't do them like this. Take it in your hand like this and let it swing, okay? Don't do this. Just let it swing so it bounces off the tendon, right?
You're lying.
I swear.
That was it. Okay? All right, so the biceps, you gotta get him to relax his arm, okay? You're holding up your arm, so you gotta relax your arm. Let me hold it up. You put your thumb on the biceps tendon and just tap it with this part of the neurohammer. Tap your thumb with that part of the neurohammer. You see his, you see it? The triceps reflex, just let it relax. You gotta hold it up. You've got a little bit of one. You see his hand down there moving. Oh, there you go. See that? You gotta tap it just a little higher. There's also a brachioradialis, if you hold it up right here. You see it move? So those are the DTRs you need to get proficient in doing. And I would measure his, you know, if you're talking about 0 to 4 plus, I'd give, if the other side was just like this, I'd say they were 2 plus. Okay? All right, so grab a partner, and I want you to grab a hammer